All right, hi everyone. We're going to start with a quick supplemental lecture from the EHDC text. This was not a chapter that you guys needed to read, but I do find that the information contained here can be incredibly valuable for those that are curious and those that want to know more about disease diagnosis and treatment. So, what is pathology? Right? Pathology is really the traits, causes of abnormal conditions that cause measurable changes in our structure or function of our body. Typically, the signs of a disease correlate with symptoms. So symptoms, remember, are the negative characteristics that result from departure from homeostasis or the body's internal balance, whereas signs are things that are objectively able to be found, right? A patient could have a symptom of tiredness, right? That is somewhat subjective. On the other hand, if we say that a patient has a sign of high blood pressure, that is something we can actually directly measure, which is primarily the difference between what we call signs and symptoms. A few terms to define. Syndrome is the collection of signs and symptoms that characterize a disease. So you might hear something called like Sjogren's syndrome, right? There are a list of signs and symptoms that are used to diagnose that syndrome. Pathogenesis are the stages of development of a disease. Acute illness is any onset of signs or symptoms that's relatively brief. We typically talk less than 3 months, but no longer than 6 months in the most extreme situations. And then the chronic illness typically is defined as anything lasting longer than 6 months. And those diseases tend to have a very slow onset in most cases. When we talk about systemic health, right? Disease within the human body really can only present in a handful of ways. We only have certain physiological pathways that become disrupted. Now we can see minor variances of those between people, which is why diseases are often defined by a list of signs and symptoms. We also have the individual factor of how well the person can adapt to that disruption in physiology, which is why we also see varied severity of disease. There's plenty of predisposing factors to all different types of disease. Age, gender, lifestyle, environment, hereditary, and immunodeficiency factors are all major aspects of disease. Now, just because you have predisposing factors does not mean you develop disease, right? Using breast cancer as an example, we always talk about the BRCA genes. You can have BRCA genes and never develop breast cancer, right? You can, on the other side of the coin, lifestyle, you could never smoke, never be around anyone that's ever smoked, never worked in an environment with lots of air pollution, but you could still develop lung cancer, right? So there's a massive interplay between some of these things, and because of the high variability of people, it's exceptionally difficult to measure. When we talk about something like age, right, there are certain conditions that only children develop. For instance, something like a Salter-Harris fracture, right? That's a special fracture of the bone that only affects the growth plate. Once someone is skeletally mature, aka they're an adult, and in most cases, for the bones that tend to have a Salter-Harris type fracture, you're looking at someone who's at least 18, but typically, lower 20s, older and older. You won't see that type of injury in those people because it's impossible. Once you're skeletally mature, you do not have growth plates, right? And the same standard, right? We talk about certain cancers. A great example, you could be talking about a cancer like multiple myeloma, which is the most common bone cancer. That typically affects people that are very old. We're talking, greater than 60, greater than 70. At the same time, we have other cancers that are thought of as cancers of childhood, things like leukemia or Ewing's sarcoma, osteosarcoma. Conditions like that tend to affect children only. Now, don't get me wrong, you could theoretically have a child develop multiple myeloma. Does that happen? Not really, right? There are rare cases where it does happen, but for diagnosis purposes, we look at age. And then you can look at gender. There are massive differences in anatomy and physiology between males and females. And in fact, because different biological sexes have different anatomy, they're going to have different physiology. So there are conditions that females or males have that the opposite biological sex cannot have. It's literally impossible. The two major things that we can change, though, are our lifestyle and environment, right? We all know that smoking and excessive alcohol consumption is bad. Risky sexual behaviors when it comes to STDs, nutrition, exercise, psychological stress, right? Psychological stress is just as important to our body as physiologic stress. The environment, this is somewhat changeable, somewhat non-changeable, right? If we know we live in an area that has slightly lower water quality, we can do things ourselves to help improve that, like adding filtration devices to the home, buying bottled water, prepackaged water, etc., from other places. When we talk about people that live in areas that experience wildfires or are, as we saw recently, you don't even have to live near them. You could be hundreds of miles away and still get inundated with smoke. You can buy HEPA filters. You can make your own filters that filter particles down to a very, very small micron level, which is highly effective, right? So there is, environment's less controllable, but we still have some power, right? And then these non-changeable predisposing factors, our age, we constantly get older. Our biological sex, that's decided before, the biological sex of a fetus is kind of decided before the mother even knows that they're pregnant, right? Those processes have already started at that point. We talk about heredity. You can't choose your family. And then immunodeficiency, now that one gets pretty complex, but there is some evidence that we can influence immunodeficiency via things like environmental factors and heredity. But for the most part, it's kind of thought that certain people tend to be more at risk than others based on non-controllable factors. Excuse me. Inflammation, right? Everyone always thinks of inflammation as a bad thing. But in reality, we need inflammation. Inflammation is normal and it is protective, right? You should kind of think about inflammation as either chronic or acute. Acute typically is that good inflammation. It's designed to help jumpstart the healing process, right? We talk about the 5 cardinal signs of inflammation. That's redness, heat, swelling, pain, and loss of function. So if you've ever, injured a muscle, injured a joint, you can see the redness, you see the swelling, you can feel the heat, right? There's a whole myriad of changes that occur. Now, if the inflammation is too intense, that's a problem, right? If it's not strong enough, that can also be a problem and lead to delayed healing. And we have different processes that affect both sides of those things. Inflammation also, remember, needs to be thought of as an immune process. It's primarily jump-started by our white blood cells and red blood cells, especially when we talk about inflammation related to blood clotting, right? That's jump-started by platelets, which aren't even full cells, if you remember from anatomy and physiology. Now, inflammation can be, both local and systemic. Typically, if inflammation is systemic, that's a problem, right? You're talking about a systemic disease at that point. It could be autoimmune in nature, it could be infectious, etc. But the whole idea of acute inflammation is to jumpstart the healing process, and it really does that with tons of vascular changes. We want to bring blood to the area so that cells like your macrophages and neutrophils, which are the cellular version of first responders, they show up and they start to break down the damaged tissue. That allows more specialized tissue like fibroblasts to show up and start producing, new connective tissue, new scaffolding, essentially. Now, again, if our inflammation lasts too long, if we're talking about the case of a muscle injury, for instance, you can end up with scar tissue and fibrosis, like a tendinosis type condition, etc. But you see here, we have a whole cascade summarizing the inflammatory process. So if you're on the acute side, we can be, think about it kind of positively. If you're on the chronic side, that's when we really have to take a step back and say, well, why are we chronically inflamed? What is causing that? Now, infection. All right. Infection can be another source of inflammation, but generally infection is caused by pathogens, right? Pathogens are essentially anything that enters the body or interacts with the body in a certain way that causes the body to not perform normal physiologic function. So the generic symptoms of infection are listed here, but specific infections can have specific patterns of signs and symptoms, right? Everyone knows that, for instance, Lyme disease can cause that bullseye rash in about half of all people. Does any other disease cause that stereotypical bullseye rash? No. But when we pair different signs and symptoms together, we get a better idea of what's going on. A few things to talk about when we talk about sources of infection. They can either be endogenous, coming from inside the body, or exogenous, right, outside of the body. So a great example of endogenous, you might have heard of a bacteria called C. difficile or C. diff. C. diff infections are relatively common in hospital situations and are associated with people that have been on high-dose antibiotics, either for a short or extended period of time. What that does is essentially kills off all of the quote-unquote good bacteria in your gut. That good bacteria in your gut actually causes C. diff to be controlled, right? C. diff doesn't divide very quickly, and it's competing with these other bacteria that are quote-unquote good for us for food. Now, don't get me wrong, C. diff still plays a role in our gut health. But if there is too much C. diff, and again, this is typically associated with too much antibiotic usage, you've knocked down the population of all these other bacteria, and now C. diff can start to take over. And that's a problem because C. diff is a highly resilient bacteria to some of our most common antibiotics. Once you have an excess level of C. diff, you can readily end up with a systemic-wide spread of it because, again, it is very resilient. Exogenous infections, on the other hand, right? This could be something like tetanus, right? You are doing some work around your house. You're putting up a new handrail, right, for your deck outside, and you've got some rusty nails, and you cut yourself on one. Tetanus bacteria lives in the dirt, loves rust. It loves dirty places. That's where you find it. It gets into your body. Suddenly you have tetanus, right? We also can talk about modes of transmission. And stuff's pretty straightforward. It's how the pathogen gets around, right? You can ingest it. You can inhale it. You can get it directly from physical contact. You could become, quote unquote, inoculated. So in the case of something like rabies, you get infected by being bitten from a infected animal. The rabies is transmitted via the saliva, and it gets directly put inside of your body. There's also something called a nosocomial infection, which is what you get from kind of being like in a hospital. Preventing infection. Again, our body has both natural and chemical barriers. We'll talk about this more in a later week. But the idea is that we have both adaptive and innate sides of the immune system. These innate immune things are very basic. Everyone has them. It's stuff like our skin that acts as a barrier. The saliva in our mouth has immune properties to help kill and break down certain bacteria that shouldn't be in our body, stuff like that. Then we have our adaptive immune system. This is what we take advantage of when we have a vaccine, right? You get injected with a antigen, and an antigen is just anything that causes an immune response. You get injected with an antigen, and suddenly the body makes white blood cells, specifically B cells, that start producing antibodies for that antigen. Those antibodies kind of act as flags for other types of immune cells like T cells, neutrophils, etc. And even macrophages can kind of produce antigen response as well that we'll talk about later. And then you end up, after that antigen's taken and cleared, you end up with what's called a memory B cell, and that memory B cell kind of hangs out and acts as, kind of the old man on the block and waits to tell people in the future about, whatever antigen was presented to it before. One minor thing to mention, what we call quote-unquote superbugs. So the most common of these is MRSA, which is methicillin-resistant Staphylococcus aureus. So it's a staph infection. We typically see that in places like hospitals, jails, anywhere with crowded living quarters. But MRSA can be very dangerous because a lot of the common antibiotics we have, it's resistant to it. And that's a major, major problem. We also have vancomycin-resistant enterococci. These typically are related to chronic care facilities, especially for elderly people, as well as the hospitals. These are also rather scary because we have very few antibiotics that even work on them to begin with. And then we have another type of quote-unquote superbug that's starting to come forward called carbapenem-resistant enterobacteriaceae, or CRE. And these guys are resistant to, again, carbapenem. Carbapenem is one of the highest level antibiotics we have and is typically considered a last resort antibiotic, meaning that this bacteria almost has no treatment for it. It has become resistant to the strongest antibiotics we have, and some of these antibiotics are actually incredibly dangerous for us to take, right? So as we develop more advanced antibiotics, they've tended to become more and more and more dangerous, right? These aren't the antibiotics you take when you get, your basic infection, like your amoxicillin, penicillins, your cephalosporins. The ones that you're given in a pill form, those are relatively benign. But we're talking about antibiotics that you have to be given under professional medical supervision because they can be dangerous. They can have life-threatening side effects, especially if they're given for too long. And suddenly, we're seeing bacteria starting to become resistant to those as well. So it is a major concern when we talk about the overuse of antibiotics, because believe it or not, bacteria do actually sort of communicate with each other, and they can share DNA, right? So if you have a piece of MRSA, you have a methicillin-resistant Staph aureus bacteria within a group of regular Staph aureus, and somebody gets treated with antibiotics, that MRSA bacteria will start to divide. It'll start to essentially share its genetics with other bacteria that will then lead to more MRSA being with that person and the regular Staph aureus being knocked out. All right, now genetic diseases. So real quick for genetics, all of our cells have 23 pairs of chromosomes. We have, based on your biological sex, there's also an X and Y chromosome, but that's also not actually very straightforward because you can end up with genetic disorders where there's, a deleted X, an extra X. You could have two Ys, one X. There's all kinds of strange things that can happen here. But The genotype is essentially the genetic code makeup of the person. On the other hand, a karyotype is the arrangement of the full chromosome set. So on the next slide, you'll actually see what a karyotype kind of looks like. Basically, it's when you're looking at the size and shape of the different chromosomes of the body, because believe it or not, they are all slightly different. Some have more genetic material than others. So as you see here, here's the karyotypes. Causes of genetic diseases, really, it's all about abnormality of the genetic code. Remember, our DNA is made up of base pairs primarily. Those base pairs code amino acids, and amino acids are used to make proteins. If you have a incorrect order of base pairs, or you have something like where something is added or deleted, you then end up with a non-functional amino acid chain, right? The amino acids get transcribed and translated. It goes to the ribosome where proteins are made, and suddenly you're getting proteins that can't be used by the body, or proteins that are non-functioning, proteins that only function in reduced capacity. Or there's even cases where the proteins function in too high of a capacity, which can also be very bad. You can also see wild things like the deletion of a chromosome or a extra chromosome, such as trisomy 21, where you have 3 versions of the 21st chromosome. That is commonly known as Down's syndrome, right? So there's lots of different things that can cause this, and there's also lots of different things that can alter DNA, and those are typically termed as mutagens. They can be chemicals, radiation can do it. Like individuals that get chemotherapy for cancer, believe it or not, are actually at an increased risk of future cancer. People that are given, especially children, that are given too much radiation for, things like diagnostic imaging, they're at risk of developing things like glioblastomas of the brain. And we even have evidence that certain viruses can cause mutations. In fact, within everyone's genetic code, there are essentially what's left over virus molecules that have kind of been embedded in there. That process is how that happens, is well beyond my understanding of genetics, but it's a rather interesting thing to talk about. And there's even viruses like the Epstein-Barr virus that are known to potentially alter our DNA. And again, this stuff is not well understood by science currently. So when we talk about inheritance, there's autosomal dominant, autosomal recessive, and then X-linked recessive. So autosomes are essentially your non-sex chromosomes. All right. So if something is inherited autosomally, it's through your non-X or Y chromosomes. If it is dominant, that means the person only needs one parent to have that trait. If it is recessive, both parents typically need that trait. And then we have X-linked, which is often referred to as sex-linked recessive. Now, in that case, for a male to have the condition, only one parent needs to have the condition. If you remember what the little plots look like when you're determining out X-linked traits, you're essentially looking at a plot that has 4. In fact, let me draw it real quick. We have a box. So we're just going to use, for simplicity's sake, X and Y, right? So you're here. So then you match up. You get an X, 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 Y, X, 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 Y. This is the basis of genetic transcription. And the idea is unfortunately, if something is on the X chromosome, there is a possibility that the male is more likely to end up with it. And we see that with something like color blindness, right? Color blindness is primarily a condition that only affects men because it actually has a lot of sex-linked dominance. So if we're using color blindness again as an example here, let's just say X1, the mother has 1 normal functioning, and then 2 is abnormal colorblind trait. That means that there's a 25% chance that the offspring is going to be born and be colorblind, but they would have to be male, right? So that's a quick rundown of that. Genetic counseling is very important for individuals with certain conditions. And you could talk about things like hereditary multiple achondrosis. People realistically need, with those conditions, they need genetic counseling, right? Especially if they ever want to potentially try to have children. There are ways to help mitigate. There's ways to test, right? And if people know that they are carriers for certain conditions, then you definitely need testing. You need that genetic counseling because, some people feel that they would not want their children to end up having certain diseases, right? And that is a fair worry to have. Cancer. Basic thing with cancer, it's got 2 sides. You've got uncontrolled cell growth, and you've got abnormally functioning cells, right? Those 2 things happen at the same time. Cancer is typically described as either malignant or benign, and then there's tons and tons based on cell type, tissue of origin, etc. Right? If you talk about tissue of origin, you could say like a sarcoma is cancer of connective tissues like bone or even muscle. Lymphoma is a cancer of the lymph nodes and lymphocytes, things like that. So benign and malignant tumors. Benign means they are non-cancerous. Now, does benign mean that they are okay to have? No, benign tumors can still cause problems, okay? Does that mean that all benign tumors need to be addressed? Absolutely not. Malignancy, on the other hand, is when cells essentially divide much quicker and they develop neoplasms that can metastasize, meaning they can spread to other locations of the body. And that is incredibly, incredibly dangerous. Here's just a quick rundown of cancer cases, types. Cancer prevention, realistically, it's tough, right? You want to consume a well-rounded diet. Avoid exposure to cigarette smoke, and not just cigarette smoke, but other types of smoke, right? This could be vaping. It could be marijuana smoke. It could be smoke that comes out of the coal power plant down the street from you. You want to avoid inhaling just about anything that is a solid, right? Our lungs do not do well with solids in them. Exposure to sunlight, specifically UV. Too much UV results in development of the skin cancers. Alcohol use is horrible as a risk for cancer. And then again, radiation and radon. Typically, we see radon as present in people's basements, which is why you often have to get radon testing done of your basement when you buy and sell your home. Other things, avoid certain chemicals. Physical activity and weight management are incredibly healthy. In fact, it's thought that obesity is one of the leading risk factors for cancer currently. And then there's other cancers that we know can be directly related to certain pathogens, like human papillomavirus, which is why it's incredibly encouraged to have the HPV vaccine. Currently, 1 in 4 deaths in the United States is cancer related, so about 25%. Treatment for cancer typically is better when earlier on. We have lots of different blood serum tumor markers, so many that it's well beyond talking about here. There's a staging system for cancer, stages 1 through 4. Typically, the staging system's based around the size of the tumor, the extent of any lymph node involvement in the area, and any distant metastases. So stage 4 is the most advanced, typically thought to be a high likelihood of fatality, while stage 1 can typically offer a good prognosis, typically detected early, and has more likelihood of having a successful treatment. There's lots of different ways to treat cancer. You can surgically remove it. You can do chemotherapy, hormone therapy, immunotherapies. There's radiation therapy, etc. The idea is, though, with cancer therapy, for the most part, the hardest part about it is that our body does not recognize it as a problem because it is our own cells. When we talked about antigens a few moments ago, our own cells actually produce an antigen that is specific to us. That sits on the surface of our cells, and our white blood cells say, okay, you belong here. You are me. We're on the same side, and does not touch it. Lets it go about its way. Cancer has that antigen, but cancer is not good for us because it is cells that replace healthy cells. It replaces healthy cells at a high rate. It creates tumors. This is a major problem when we talk about changes in function, because again, these cells do not function the way they are supposed to. So unfortunately, the best way that we can kill cancer is to essentially poison ourselves. And, you know, as morbid as it sounds, it's a matter of what dies first, the rest of us or the cancer. And typically, when you catch cancer early enough, there's not a lot of the cancer. So the poison kills the cancer way before we have these major long-standing problems. Now, more advanced cancers take longer treatment of chemotherapy and radiation, which again, toxic. They're bad for us. But unfortunately, because of the nature of cancer, it's hard to mark cancer cells, though we are getting better at marking specific cancer cells. And in fact, some highly specified types of cancers have relatively successful treatments because we have found ways to reliably radio mark those cells and target them with highly advanced chemotherapies. Not all cancers are that way, though, unfortunately. Another interesting thing is the idea of a cancer vaccine. This is that same type of idea. There's still a lot of stuff under the hood, behind the scenes going on with this. But it is a potential promising area of research, and we already see some human trials being done that do currently have some promising results, right? Everything I know about it shows that drugs like, I think it's called Prevenge, are relatively asymptomatic. And again, that's just the one I can think of off the top of my head. People don't really have major side effects from it, which is so much better than something like chemotherapy. Just a quick mention, hospice care is typically used for terminally ill individuals. The idea is helping somebody reach a compassionate end of their life. We focus on things like pain management and reducing the load on the person's family for taking care of the person at the end of their life. The idea is hospice care is not supposed to hasten or postpone death, but it is supposed to make it more comfortable for everyone involved. Now we talk about immune disorders, broken down into three kind of areas: hypersensitivity reactions, which there's multiple different subtypes, autoimmune diseases, and then immunodeficiency disorders. The whole premise of these disorders, though, is that you have an inappropriate immune response to an antigen. So again, hypersensitivities. These are our allergic reactions. Again, there's different types, but for our purposes, we're going to stay pretty vague currently. Remember, antigen is something that the body sees and says, hey, you're not me. You shouldn't be here. I need to attack and destroy you. With hypersensitivity reactions, we end up having a stimulation of immunoglobulins, specifically antibodies. Antibodies are made by our B lymphocytes, which are commonly subtyped to be called plasma cells. they make immunoglobulins. We have 5 different types of immunoglobulins. With hypersensitivity reactions, we get a major increase in IgE, so immunoglobulin E. This is why your allergic reaction for something like seasonal allergies involves, your runny nose, cough, sneezing, stuff like that. You can also see IgE reactions that result in things like diarrhea, swelling, like in the case of anaphylaxis. Allergies can vary a lot based on their the number of exposures and the severity of our response to them. And typically with allergens, you won't actually have a full allergic response until the second time you're exposed. We can also get weird things that happen, especially with pregnancy, where people can develop certain allergies only while they're pregnant. There's lots of interesting ways in which pregnancy affects the immune system. There's also people that have allergies before they become pregnant, go through their pregnancy, and they no longer have that allergy. It's incredibly fascinating stuff. So you see here is a quick rundown of the mechanism of allergic reactions. You could pause here and read through it if you want. But the main driver at the very end of it is a substance called histamine, which is why when you're taking your seasonal allergy drugs, they're commonly classified as antihistamines. So autoimmune diseases and immunodeficiency. So these two things are important and can kind of be classified together because they come from the fact that the immune system is no longer able to accurately determine what is a self-antigen and what is an outside antigen. So our immune system starts to not operate correctly. We start to form antibodies against ourselves, right? You could see something like Hashimoto's thyroiditis, right? That is the most common form of hypothyroidism, and we'll talk about that in a future lecture. But Hashimoto's thyroiditis is something that leads to autoantibodies against the thyroid peroxidase, which is a enzyme that's used in the production of thyroid hormone, right? So you're actually getting the body destroying that enzyme, which means we get a reduced level of thyroid hormone, which is the basis of hypothyroidism. On the other hand, immunodeficiency is often secondary to certain diseases, right? HIV is a prominent example here. HIV actually renders the subtype of T lymphocyte, the T helper cell, renders it useless, and the body underproduces it. And without the T helper cell, the other T cells and many of our other white blood cells like macrophages, neutrophils, etc., they don't function as well. That's why people that actually have HIV, they don't tend to directly die from HIV. They actually die from secondary infections, right? A lot of times it's stuff like pneumonias and very strange, not common infections that the average person could deal with very readily. We can also talk about physical trauma, chemical agents. There's lots to this, but it's well outside the scope of our class. So, what is aging, right? Generally, the idea of age, as we talked about, it comes with its own risks of health conditions. As you age, you tend to want to get different tests. Like for a man, as they hit 50, 55, they're going to start getting PSA, prostate-specific antigen testing, looking at prostate health to determine if they have benign prostatic hyperplasia or even are developing prostate cancer, right? We have all these different things like that. Psychological factors, again, I think at this point it's well understood that our mental health is heavily related to our physical health, and there's also a very, very, very interesting relationship between our digestive system in our mental health. And that's primarily because of the bacteria that naturally live in our digestive system. There's even evidence that talks about how if our immune cells that are related to our digestive system are in a pregnant woman, if they're making too much of interleukin 17, that actually, and interleukin 17 is a cytokine. Cytokines are inflammatory mediating substances, right? And interleukin 17 specifically primarily causes inflammation. Now remember, acute inflammation is not a problem, but as we talk about inflammation over the long term, like over the course of 9 months of pregnancy, something like too much interleukin 17 actually seems to have a association with the development of autism in if a fetus is in utero of someone that is pregnant and there's too much interleukin 17 being released. Now again, this isn't necessarily a causation, but there is an association, right? And this tells us why there's it's another example of why there's so much interaction between so many of the factors we talked about earlier. It would be almost impossible to outright say interleukin 17 causes autism, and in fact, that would be a incredibly highly unlikely direct causation. It is likely that there is some sort of process there related to interleukin 17. What that process is, we don't know yet, right? We've already shown that happens in the... we can actually force it to happen in animals, and we know from just observational data that it's relatively true in humans. But also when you talk about mental disorders, right? You can have certain mental disorders that directly alter our physiology, right? Because ultimately mental disorders come back to dysfunctional physiology, just like every other type of disorder. Depression and anxiety are linked to dopamine, serotonin, norepinephrine, right? Neurotransmitters. You can talk about depression also being linked to non-neurotransmitters. Like we know for a fact with a form of depression called seasonal affective disorder, typically associated with not getting enough sunlight because your body's not making enough vitamin D, because our skin synthesizes vitamin D. Incredibly interesting topic. But there's this amazing relationship between these things that has been overlooked for so long, and people are finally turning around and saying, hey, maybe we do need to pay attention to this stuff. Diagnosis. One of the most important parts of diagnosing a disease is your medical history, right? That's the conversation you should be having with your provider. Now, a lot of times you're going to be given a form to complete that's going to ask very specific questions. If you're at a specialist, there's going to be questions specific to what they're looking for. If you're at your primary care, lots of stuff to just fill in the blank, answer generically, etc. But they like to say that 80 to 90% of your diagnosis comes from your medical history, because you use your medical history to then do your physical exam, right? That's looking at the person. That's, doing things like listening to their heart rate, or even in the case of, you talk about orthopedic testing, you're doing all those types of things. And then you use the results of that to say, okay, I have a differential list. Is there anything I can do to narrow this list down? So you might say, okay, using a really easy example, you could say this person, I've got a list of 3 potential injuries to their knee. How can I confirm that? Well, you do a diagnostic study, you send the person for an x-ray, and then an MRI. So this is just a quick rundown of kind of the steps of diagnosis. So treatment of disease. In reality, treatment should include preventative measures, but a lot of times treatment in Western medicine is aimed at being reactive to something that's already there. A lot of our treatments are actually related to symptom modification and don't actually address the underlying problems, right? Like I said before, with an allergy, a seasonal allergy, You don't take immunosuppressant drugs to stop a seasonal allergy in 99% of the cases. You take an antihistamine. So what does that do? That shuts down the production of histamine. We're not stopping any of the processes that are occurring before the production of histamine. We're not addressing the root cause. We're actually addressing the symptoms that can be disruptive, because we know that in the case of a seasonal allergy, it's not life-threatening. It's not a problem. The symptoms are what's annoying, right? We like to address symptoms for a majority of our diseases. And the same thing happens with, you stub your toe on your coffee table and your foot hurts, right? So what do? You take a NSAID or Tylenol, right? Tylenol just being an analgesic, and NSAIDs are non-steroidal inflammatories like ibuprofen. Those help stop pain. They help stop, the NSAID helps stop swelling as well as pain. And you're not addressing the potential damage that's caused. You're just dealing with the annoying fact that your foot hurts, right? Holistic medicine. So really the idea of the holistic viewpoint kind of can be summed up with the idea of the biopsychosocial model. That's been expanded a little further into even more things, but the idea is you have to address the biological problem, the psychological effects of that problem, and the social effects of that problem, right? If a person has a chronic disease, do they have a good support network? Do they have people to talk to? If they don't have a support network, are they depressed? Do they have an issue on that side of things? And then biologically, what can we do to help address that problem? It's addressing the person as a whole. When I first did my first internship in healthcare at New York University's Langone Medical Center, it was that concept was one of the most important things. Sometimes you can get someone better by just talking to them. It's a wild thing, but especially when you're talking about chronic pain patients, sometimes they just need someone to talk to complete that biopsychosocial, connection, which allows them to really start healing themselves. Cultural diversity, another major thing to talk about. It's estimated that there's over 40 million people that live in the United States that are not American citizens, right? 40 million is a large number, especially the fact that our population is currently a little bit under 400 million. That's a little bit over 10% of the population. Not everyone's going to have major differences with you, but other people realistically will. And we need to be prepared to handle those things, because those people are going to have differences in language. They have different religious beliefs. They have different views about health issues, right? You always hear examples of certain religious groups. They'll refuse blood transfusions, right? Even though they're going to die without it. You'll see parents all the time. Well, not all the time, but every few months, makes national news. You'll have an individual, a child that's 11, 10 years old. They get into an accident. They have a massive loss of blood. Their parents, because of their religious beliefs, will not allow a blood transfusion. The kid's going to die without it. So you see this rapid court case unfold, right? And some of the outcomes of these things can be very unfortunate for people that are involved. But the importance is when you're working in healthcare is you have to balance these things, right? And it's important to respect people's beliefs, because ultimately we cannot force them to have treatment in 99% of cases. Another cool thing that's been going on is gene therapy. We're starting to see new ways to not necessarily cure, but treat and reduce the issues of genetic conditions. Some of the things that we've seen a lot of good success with are conditions like cystic fibrosis, and sickle cell anemia, and then certain types of hemophilia, various forms of cancer, etc. As new technologies like CRISPR become more effective, we might actually start to be able to truly edit genetic sequences. We're still a long way off of being able to do that, but at least in a living human. But we have seen some good results in relatively genetically simple animals. In fact, when I was doing my undergrad, I took a graduate level genetics course, and we used CRISPR in that class to edit the genetic sequence of a creature called a C. elegans. They're a type of nematode. They're microscopic. You look at them through a microscope. And we actually, in that course, my group specifically did an experiment on them where we gave them a human disease. We actually took the genetic sequence associated with Duchenne muscular dystrophy and gave it to the C. elegans. And over the course of a week or two, we observed how they changed. And we actually saw essentially them develop the C. elegans version of muscular dystrophy. They stopped moving as much, they became amotile, and they actually eventually died because of it. Another thing we're seeing a lot of progress in is stem cell research. A lot of what the idea of stem cell research is poorly understood by a lot of people, but the idea is you're taking undifferentiated cells, right? You're taking cells that could become using a really easy example, an osteoblast or an osteoclast, right? Remember, osteoblasts build bone, osteoclasts break down bone. We need both of those working together to remodel bone, keep bone strong. Well, what if a person, has osteoporosis? They've become old, their osteoblast activity is reduced, but their osteoclast activity has not changed. So they start to reduce their bone density. They become at higher risk for a fracture. Well, what if we could, in a lab, take the precursor cell to osteoblasts, and we can say to that person, all right, we can use this factor, we're going to give you these extra cells, and we can then give the cells the environment they need to become osteoblasts. And that's kind of the idea of stem cell research. We're even seeing this used for things like degenerative disc disease, osteoarthritis. There's lots of promise, but we are still a far bit away. Next thing, we're going to talk about pain. Now, it's important to remember, pain is a subjective experience. Pain can be physiologic, it can be psychologic. In fact, physiologic pain can be made better or worse based on psychological status, right? People that are depressed tend to suffer worse pain given the same type of injury as another person. Pain can be described in different ways, and it can be associated with different emotions. We have different types of pain scales. Some are useful for children. Some are useful for when we have language barriers. Some are sliding scales. All these kinds of different things. Pain is considered a vital sign, though. Just like your blood pressure, heart rate, pain is considered a vital sign. There also is a lot of debate of whether pain is a sense or a perception. And in reality, it's a little bit of both, because we do have special sensors in the body who their entire function is to signal pain. So yes, there is a sensory, there is a sense function there, but it is also there's a perceptual component to it. What you see right here, the smiley, it's called the Wong-Baker face scale. It's typically used for children. So physiology of pain, lots of different things to talk about here, but the idea is that pain is signaled by receptors called nociceptors. There are two types of pain. There's quote unquote your slow pain, which is type C nerve fibers. Typically that's your burning type of pain. You have fast pain as well, which is your which is sharp pain, your stabbing pain, things like that. Pain receptors can also be triggered by temperature extremes, mechanical damage, chemical damage, etc. So there's lots of really interesting things that are coming out about pain and about pain's effect on the brain too. Referred pain. So there's different patterns of pain referral as well. What you're seeing here is things, this is like visceral patterns, but we also have something called sclerotogenous patterns, right? So this would be stuff for like trigger points, or you talk about like disc degeneration. So a person, let's just say we have, like your C2 disc, this is a little low for C2. So let's just say C6. Your C6 disc could be causing pain in the person. Where would that refer to? Well, for C6, you could start to get pain referral down this way. If we're higher up, you could get pain referral in this area, things like that. There's different ways to classify pain: acute, chronic. There's intractable pain, which can be associated with psychological conditions, but intractable pain can also be associated with more severe conditions like cancer, right? If there's nothing you could do to stop pain, you have to kind of raise a red flag there. If pain is transient, that can be important, but sometimes it's really not. Pain relief, there's lots of different things that we can do. One of the past favorites is narcotics like opioids. But we've actually found, obviously the major problems with opioids are related to addiction, changes in our nervous system. They're not very good for people to take long term. But a lot of research has actually found in surgical patients that ibuprofen and Tylenol at certain dosage actually have the same pain-reducing effect as opioids based on the survey of the patients in those studies, which is rather interesting. Chronic pain typically is dealt with things like NSAIDs and antidepressants, because again, chronic pain can have a change on the brain. That change primarily starts with a area of the brain called the thalamus. The thalamus can be thought of as the relay center of the brain. So as signals come up, they then get processed and sent to the correct region of the brain to interpret them. But right next to the thalamus, there's also a feature called the periaqueductal gray matter, which is associated with pain signaling in the body. And you can get kind of almost like a spillover type effect. There's also talk of changes in the microglia, which are, if you remember from A&P, microglia are your support cells of the nervous system. So they're not neurons, but they support the neurons. One of the common types of microglia are dendritic cells, which are kind of like the white blood cells of the central nervous system. And you get an increased presence of dendritic cells, which leads to increased inflammatory mediators, those cytokines I mentioned before. And you can actually have essentially a proclivity for increased pain transmission even when it's not appropriate to have that increased transmission. It's rather complex, and we're still learning new things about this every day. Now, there's alternative methods to pain relief, and one of the primary overarching themes of many of these alternative methods is something called the gate control theory of pain. The idea is chronic pain tends to be more of that slow transmission pain. Well, we can override that in the thalamus. Again, all of these things go to the thalamus, and the thalamus then sends pain, whether it's slow or fast, as well as other types of sensory input, whether it's temperature, it's pressure sensation, it's the sensations of proprioception from our muscle when you're talking about input from your Golgi tendon organs or your muscle spindles. That all goes through the thalamus at the same time. So if we have a injury to our knee, for instance, we can do multiple things to kind of override that pain. As long as we are sending nervous impulses that are faster than the pain. Because again, chronic pain is typically that type C fiber. It's very slow. And so if we do things like electrotherapy, like TENS units, which are transcutaneous electrical nerve stimulation, you just put a couple pads on the skin, you turn it on, you feel a little tingling. Guess what? You're overriding that pain signal. Highly effective, as long as you're running a TENS unit. You could theoretically run a TENS unit forever. On the other hand, you could do things like exercise. You override the pain signaling that's happening because there's all kinds of signaling coming from the pressure fibers, the Golgi tendon organs, your muscle spindles. All of that overrides the pain because the thalamus says, hey, this is more important, right? So the idea is, for a lot of our alternative methods of pain, we want to kind of overload the brain with sensations, and the brain will actually not pick pain, especially slow transmission pain. It will override that with all of our other sensations. Preventative healthcare, highly variable in nature, often overlooked. Education for people is a major part of preventative healthcare. The idea is we just want to give people strategies of preventing illness or injury. We've already talked about some of this before, such as the health effects of tobacco smoke, talking about that, talking about the health effects of alcohol, talking about exercise, diet, obesity, all of these things, incredibly important. Preventative care also, we talk about infection control, things like vaccines, talking about proper hand washing, public safety. We often don't think about it, but one of the leading causes of death in children in the United States is actually being hit by vehicles. So teaching younger children the idea of public safety, look both ways before you cross the road. And you could even talk about more other topics like, stranger danger, stuff like that. Non-traditional medicine. So these are things that are complementary by definition. These things typically rely on not using medications, or at least medications as would be defined by organizations like the FDA. In fact, some natural medicines are medications, right? When you talk about acetylsalicylic acid, which is your Tylenol, acetylsalicylic acid actually comes from a willow bark, a special type of bark from a certain type of willow tree. And the pain-relieving effects from that were actually discovered by people who would chew the bark, right? They would have minor effects. And so what we did with the drug is we basically just concentrated that to a little higher degree, and turns out it works relatively well, right? We also have other things. Smelling, smell is something that's often overlooked in the body. There's a lot of newer research that talks about how the sense of smell can degrade in individuals that are developing certain neurological conditions like dementia or Parkinson's. In fact, for those two specifically, there's some evidence that a diminished sense of smell can be present up to a decade before symptoms of Parkinson's or dementia actually start. What you see here is just a quick look at a lot of the acupuncture sites on the body. Acupuncture is a rather interesting form of treatment. And again, it relies on that gate control theory of pain. There's different forms of acupuncture. There is very Eastern medicine forms that aren't very well founded. And then there's more Western medicine type uses of it, like dry needling, where we're actually using the needle to break up trigger points, for instance. But again, the idea is that we're utilizing our body's sensory inputs to override other signaling. There are plenty of people that swear by acupuncture, and there's some rather very interesting acupuncture studies that exist, such as the study that came out of Germany that included over 13,000 people where they talked about how in a blindfolded person, you could poke their right arm and it would help with their left arm pain, as just an example. It's rather interesting things. Principles of patient teaching. Again, patient-centered care. We want to focus on that biopsychosocial model. We want to focus on the whole person. Sometimes, though, the most effective part of patient teaching is listening. That's going to help us pinpoint how we approach the individual patient. And this can be summarized, if you want to learn more about this type of process, motivational interviewing is the kind of overarching theme. There's plenty of material online, highly effective. You kind of talk to the person, figure out strategies that fit into their life, their values, that also address their health problem. And you're going to get better results that way than forcing a person to follow a health improvement strategy that does not fit their values. If we fit their values, they're going to have greater compliance. They're going to end up with better outcomes. They're going to be more trusting. There's going to be a better relationship between the provider and the patient. Again, all of the reasons here. Addressing patient concerns. Now, this is a big one, right? Especially when we talk about something like informed consent. You need to discuss risks, benefits, and reasonable alternatives to care. And a big part of educating the patient is risks of medical care. There's risks to everything in medicine, right? Believe it or not, it's unfortunate, but the third leading cause of death in the United States, affecting about 500,000 people a year, is medical errors, right? Physicians, PAs, everybody that is a medical provider is a human. They can make mistakes, right? And the mistakes aren't necessarily anything that they can or cannot control, right? There's plenty of situations where a provider can do everything right and a patient would still die. Now, is that considered a medical error? I don't know. But there's also outright errors. And it's important, even in those situations where an error is not made, that the patient understands risks. Every surgery has risks. Every medication has side effects. It has risks, and we need to talk about the reasonable risks, the things that happen all the time, as well as the most uncommon, most severe types of risks. You could, talking about like an NSAID, like your ibuprofen, for example. Most common side effect could be anything from, GI upset, little diarrhea, or maybe stomach hurts a little bit. But long-term use of NSAIDs can be fatal. You can talk about destroying the kidney if you take too much or you take it for too long. Talk about eroding the lining of your stomach and small intestine. It can be incredibly dangerous, and those are things that need to be mentioned. Preoperative and postoperative care, a big thing. This is all about communication, and being effective. Postoperative care, this is a lot of patient education. Once the surgery's done, if there were any complications that might warrant specialized education, specialized care afterwards, all of those things are important to provide the patient, and it needs to be given to the patient in a way that they can understand and that they can potentially describe to other people. Special considerations, cancer and life-threatening disease. This can be a topic that is tough to approach for a lot of people. And it's very, very difficult for the patient as well. But it's important to remember that these people need support, and the biopsychosocial model is even more important in these patients than any other situation. And it's important, when talking to these patients, you temper expectations and you give them the facts. A lot of people will be more appreciative if they are given direct facts. All right. People don't want to be given hope when there is no no reason for them to have hope. You know, if somebody has a stage 4 brain cancer that's already metastasized out of the brain, they're starting to lose neurological function. There's no surgery that's going to help them, and you know, the brain's already a tough area to treat. Anyway, you know, you don't want to provide the person excess hope. So that is everything for this first quick little overview lecture about disease. We'll dive into a lot of these topics more in depth in a later week. As always, if you guys have any questions, please make sure to ask via email, Ask Your Instructor, or at any other point.